you see at the very top of the screen on this slide, it says assumptions plus data implies conclusions. That's either something very trivial or very fundamental that I repeat to myself all the time and to students as well. And the data are fairly weak on COVID. And so anything that you've been seeing about it requires connecting the data with some pretty strong assumptions to try to interpret the data. And what Francesca and I are trying to do, and this is kind of formal econometric work, although there won't be any math in what I present, is to try to understand formally how the data and assumptions combine to see what conclusions we can draw. So the particular focus is going to be on the basic statistic, is what the infection rate actually has been to date. And I'm sure everybody sees statistics on that day in and day out. And there's a multitude of problems. We're going to focus on two of them. First, there's a quite obvious missing data problem, is that the statistics that are reported on a daily basis are on what are called confirmed cases. And to become a confirmed case, you have to be tested, and then you have to have a positive test result. So there's no data at all, of course, for people who have not been tested. And the people who have been tested may differ significantly from people who have not been tested. I don't know whether anyone listening in on this has been tested, but I'm sure everybody knows that with tests being not that readily available, there are kind of stringent criteria that have been used to determine eligibility for testing, that either you have to have symptoms associated with infection, and in many places they're quite severe symptoms to be called deemed eligible for testing, or you have to have had close contact with infected people. So we have, and the fraction of people who've been tested, I'll come back to this later, across the United States, it's roughly about 1%, okay? So it's about 99% of people have not been tested. And all these 99% who have not been tested, it seems clear that some of them actually have been infected, but maybe typically have mild cases, maybe asymptomatic, or maybe they'll develop severe cases, but so far they're pre-symptomatic. So we just don't know what fraction of the untested people actually have been infected. What that means is something systematic. The actual rate of infection has been higher than the reported rate. I think that's a problem that most people are quite aware of. It's been discussed often. There's a second issue that has received some attention, but not nearly as much. And it's one that we all need to be aware of if we're actually tested ourselves, is that the prevalent tests for infection, these nasal swab tests, are not fully accurate. And moreover, there's a great asymmetry in it. There are two measures of accuracy we'll talk about. One is the positive predictive value. And positive predictive value mean if you did receive a positive test result, what's the chance that you actually have the disease? And the positive predictive value there seems to be consensus that that's very close to 1. I talked with one infectious disease expert at Northwestern at the Feinberg Medical School. I've seen a lot of reports on this, and there seems to be consensus that if you get a positive result, then yes, you really do have the virus. The other hand, there's a negative predictive rate. Let's say that you get a negative result on the test. Does that mean that you're clean, that you are not infected? And that seems to be far more problematic. The negative predictive rate, the chance that you're not infected, given that the test says you're not infected, is substantially less than 1. Francesca and I spent a fair amount of time trying to see exactly what's known about, what is it? I mean, if you get a negative test result, does that mean you just have a 1% chance that you're actually sick, or a 5 or 20% chance? And we really couldn't pin that down. So what we did is we actually put a bound based on, we don't really have expert opinion, but we're sort of based on whatever we could learn, that the negative predictive rate is between 0.6 and 0.9. Or to put it the other way, that if you get a negative result, your chance of being infected is between 0.1 and 0.4. And the formal analysis we do uses that bound. Let me mention just on the side that for those of you, if anyone listening in has a medical background, you may be well aware that the way the test accuracy is measured is not always by positive predictive value and negative predictive value. Very common in the medical literature to talk about the sensitivity and the specificity of a test. There's a mathematical relationship between those and the measures that I'm talking about here, which we can't get into, but which we discussed the relationship between them in the paper. The impact of having so-called false negatives, that some people get negative test results, but they are actually infected, adds to the reason why the actual infection rate is higher than the reported rate, because some people who test negative actually are infected. So the actual infection rates are higher from that perspective as well. So if you put these two together, the missing data problem and the imperfect test accuracy, you have this conclusion that reported rates are lower than the actual rates. Now, that's about the infection rate itself. The infection rate, that basic statistic, is used as an input into various other statistics that are critical. Because really, you know, if infection's mild, sort of who cares really? If you have a mild case of the flu and you get over it, it's no big deal, at least for yourself, although of course you may contaminate others. But what of course enormous concern is for the rates of severe illness, rates of hospitalization, treatment in intensive care units, and of course death rates from the virus. So if we want to compute any of those rates, you take the data on how many people have been hospitalized and how many people have died, and you divide that by the infection rate. So the infection rate's in the denominator of those rates of severe illness. And if you get the infection rate wrong, then you're going to get the rates of severe illness wrong. And this has been a very, very serious matter. Let me to jump ahead, we're going to present data for Illinois and New York and for Italy. And in Italy, there were death rates were, you know, just nominally among people who were viewed as infected were extremely high, like at 12%. But that, of course, that's likely much higher than the actual death rate because the rates of infection have been undercounted in the official statistics in Italy. So we'll come back to that later on. Now, I think there's general awareness of the uncertainty. To deal with the uncertainty, all kinds of researchers have made all kinds of assumptions to add to the weak data in order to generate point estimates of these quantities, and not just point estimates of the existing infection rate, but also to forecast future infection rates and rates of severe illness. I don't want, this is not what I'm going to be discussing at all, but I give two references here that have received an enormous amount of attention. These are epidemiological studies performed at Imperial College in London, which had a very strong effect on British policy and has also affected American policy. And then here in the US at the University of Washington, Institute for Health Metrics and Evaluation. That's what you'd probably see quoted day after day now on forecast of what future death rates and illness rates will be. And what they're doing is that they have access to the same data that I just talked about, but they add all kinds of assumptions to that to come up with their forecasts. Now, the available estimates in the forecast, they differ quite a bit. And the assumptions that people are making differ quite a bit. But there's no consensus at all about whose assumption's right. It may be that all of these epidemiological models are wrong, okay? So that brings us to what we do in the paper. And this goes way back for work that Francesca and I do, this kind of work that I've been doing for 30 years, and Francesca's been doing for 20 years at this point, is that we think it misguided to report point estimates obtained under assumptions that are not well justified. We think it's more informative to determine the rate of the range of infection rates and the range of rates of severe illness that are implied by a credible spectrum of assumptions. Now, there's a very long-standing way of doing this, of maintaining different kinds of assumptions and seeing what kinds of results you get and trying to deal with uncertainty that way. So in many disciplines, that's called sensitivity analysis. And a common practice is to obtain point estimates under alternative strong assumptions and then present a range of estimates. The problem with traditional sensitivity analysis, at least the way it's traditionally been practiced, is that someone may put out this assumption or that assumption, but none of them may have a good claim to realism. So sensitivity analysis is clearly a step in the right direction, but it doesn't go far enough at all from our perspective. So what we do is we bring to bear econometric research on partial identification. Anyone who knows me or Francesca, or anyone, if there's anyone present or former students from Northwestern who were listening in, then you certainly know what partial identification is, but I'm sure many of you don't. The study of partial identification just removes the focus on estimation under strong assumptions entirely. Instead, what we do is a kind of a sequential process. We start by posing very weak assumptions that should be highly credible in the applied context under consideration. And the desire for credibility is extremely important for us because you can obviously get any conclusion you want by making strong assumptions. But we want to ask what you can get that's credible, that's believable. Now, if you do that, then you have weaker assumptions and you just can't make as strong inferences. So typically in the formal work on partial identification is that you, under combining the data that's available with the assumptions that you find are believable, you can't get a point estimate of anything. Instead, you may be able to get a bound. So mathematically, formally, it's a set valued estimate, but just think of it as it's a bound. Instead of being able to say, for example, that 10% of people have been infected, you may be able to say it's between 5 and 15%, or between 3 and 80%, depending on the case. So you have to feel comfortable reporting results as bounds rather than as point estimates. Of course, you make stronger assumptions, you can narrow the bound, and that's the kind of work that we do. At the bottom of the slide, you see some references. I've written several textbooks on this and enormous amount of material. Also, there's review articles, including one by Francesca that you can get off of her webpage if you want. And of course, the paper, if you go online and get that, has all the references. Okay, so let me talk about the methods briefly, and then I want to get to the results. So there's all some, underneath all of this is some very simple math. It's just very basic probability ideas about laws of total probability and Bayes' theorem and, you know, the most basic mathematical probability theory, which we're not going to put up on the slides at all. But anyone with even the barest undergraduate probability and statistics background, I think, should be able to understand the paper easily. So what we do is we first consider the problem abstractly, and then we impose some bounds, some assumptions that we think have some credibility. And these are certain monotonicity assumptions, which I'll explain in a moment. Once we get the bound on the infection rate, then we use that as the denominator on trying to estimate the rates of severe illness, and we get bounds on severe illness. And then, of course, we're going to just talk about doing that over for the population as a whole, but you can condition on any attributes that you want. So I'm sure everybody is aware that the infection rate, well, the infection, not so much the infection rate, but this rate of severe illness has been seen to be much higher for older people than for younger people. There's been lots of discussion just in the past few days about racial differences in both rates of infection and in the severity of illness. And so all the analysis extends to that, but we're not going to do that conditioning on patient attributes here. We'll just stick with the basic problem. So there are a couple of formal results we show. This is actually in some simple formulas. There are two uncertainties that I talked about. There's uncertainty about the accuracy of the test and the bigger uncertainty about the infection rate of untested people. And they combine in a very simple linear fashion to yield uncertainty about the population infection rate. And then if you think about the fraction of people who've been tested and untested, those two forces combine as well. And for right now, as of, we're in the middle of April, the dominant issue really is the fraction of people who have not been tested, because as I said at the beginning, the fraction who have been tested is really only about 1%. And I'll give more specific statistics for a few places in a moment, but it's just about 1%. So there's about 99% of people who have not been tested. And it doesn't require any math at all to see if you knew nothing about what's going on about those 99% of people, then you can barely draw any conclusions at all. And that would be true even if test accuracy were known precisely. So let me just make a kind of a side comment here that there's been a lot of discussion about the need for increased testing. And I think one has to be very careful about interpreting this, about what would be the value of increased testing. from a clinical medical perspective, increased testing would be good, because then more people would know personally whether they actually have the virus or not. That's fine. But I think it's misleading to think that just an increase in testing per se, using the existing criteria that you have to be symptomatic or have to have close contact with someone, would solve the problem. Because if we're starting off with 1% people who've been tested, even if we were to do that 10 times and have 10% tested rather than 1%, you would still have uncertainty about 90% of the people. So just increasing in testing is not really going to do very much unless we got up to 50, 60, 70, 80% of people tested. The real issue, which has been very well recognized among statisticians working on this, is that what we need is random testing of the population. And random testing does not require having a very large number of people tested. There's the kind of the magic beauty of random sampling is that if we were to just get 5,000, 10,000 people tested out of 300 million and know that it's a true random sample rather than a selected sample, there's an enormous amount that we could learn. Many statisticians have been saying this since the beginning of the pandemic. As in the United States, I have not seen any moves towards random testing yet. People have been pleading to do it, but it just has not been done. So again, I won't say anything further about random testing for now, but that's it's an important point to make. Okay, so as I said, we bring to bear two assumptions because the kind of testing that's been done is very non-random, it's very selective. And so the key assumption we use is what we call testing monotonicity, which is, as shown on the slide, that the present criteria require a person to show disease symptoms or to have been in close contact with someone who's tested positive. Well, if you think about that, then Francesca and I came to the conclusion that this would be credible to assume that the infection rate among people who have been tested is higher than the rate among untested people. Okay, so if we get to observe some tested rate among some infected rate among people who have been tested, then the people who haven't been tested, they must have a lower rate of infection. It may be just a little bit lower, it may be very much lower, it could even be zero, but it's going to be lower. So that's a formal assumption that lets us get some results. There's a second assumption here which just comes free, temporal monotonicity, which I don't really want to get into. It just says if we're looking at this over time, and over time the fractions have to increase just logically, because a person who's been infected by an early date necessarily has been infected by every later date. So that's not really an assumption, that's just a logical condition. So those are the only two assumptions that maintain. Okay, that's all I'm going to talk about on the methodology. You can go to the paper and see the math to get behind it. So let me go on and talk about the data and the results, and then some close-up comments, and then we'll conclude, because I know we want to keep this to just 30 minutes, and I'm watching my clock here. So we could do this from anywhere, but I'm sitting here in Illinois. Francesca's in New York. Francesca, being Italian, also has some personal interest there, and I think everyone's been interested in the situation in Italy as well, given how high the problem has been there. So we decided to focus on Illinois, New York, and Italy. The data sets are sources are official data coming from different departments of health in the United States and the Italian equivalent. The data are the data that you see discussed every day. First, cumulative counts of the number of persons tested and number of positive test results. We have that data daily from Italy from February, and then in March in Illinois and New York. We actually used the data in the paper only beginning March 16th because we wanted to have a common starting point at a point where there were enough cases to make it interesting. So we started on March 16th because there were at least 100 confirmed cases as of that date in all three places. For Italy, we have more data than we do for the US because we actually have the counts of a number of people who've been hospitalized, treated in an intensive care unit, and death. And if the US, we don't have it for hospitalization and treatment in intensive care unit, so we can't present results for the US now. The data must be there underneath, but we didn't have access to it. Okay, let me go first on the results. First, what's in the raw data, the inferences that we draw from the raw data. Over this period, March 16th to April 6th, the fraction of people tested increased from 0 to 0.5% in Illinois. It increased in New York from just 0.1% to 1.7% in New York, and in Italy from 0.2% to 1.2%. So that just verifies what I said before, that basically it's about 1% of people being tested right now at different locations. Now, the fractions of positive test results are quite different from place to place, because the testing protocols from place to place, what it takes to be tested differs from place to place, and also the severity, the rates of illness. So the fraction of positive test results has varied during this period from about roughly 9% to 20% in Illinois, from 13% to 40% in New York, and in Italy it stayed roughly around 20% across the people test positive. We have a caution here against comparing these quantities across places or over time, because the criteria for testing, the accuracy of the testing may be different across locations and time. Now, for Italy, we also have the the rates of severe illness, and these fractions on the slide look very, very small, because this is taking the number of people hospitalized divided by the entire population size of 60 million or 70 million or whatever it is in Italy. So those are small fractions of the entire population. Of course, they're much larger fractions of the affected people, but you can see what those rates are for in the raw data from Italy. Okay, now these are the ultimate results. This is a class, when you do partial identification analysis, you get used to having a cup half full and half empty. That we would like to get very strong, tight bounds on things, but getting strong, tight bounds on things requires assumptions that just may not have believability. On the other hand, if you assume nothing, you're not going to learn anything. So we make some assumptions that we think are credible, but they're not that strong. These are the monotonicity assumptions. And what you can get for those assumptions formally, just by going through the simple equations and then plugging in the numbers that I just talked about, is bounds on the actual infection rate as opposed to the reported infection rate in Illinois, New York, and Italy, that it really is sort of half full and half empty, because these bounds basically have a width of around 0.5. Because if you knew nothing at all, you would just say the infection rate's between 0 and 1. So the bound would be of width 1. If you knew everything, the bound would be of width 0. But we're able to narrow this down to about half that length. 0.1% to 51% roughly in Illinois, again 0.1% to 65% in New York, and then very low 0.3% to 51% in Italy. Now, the fact that these bounds, as of this time in April, are still the width is so substantial is because 99% of people have not been tested. So if we assume nothing, you would just get a bound that's of width 0.99. We're able to basically cut that in half. So there is some information content in this. And if you've been looking at all the point estimates that have been around, they're all over the place. If you take the data at face value, the infection rate's been very low, but I've seen reported in the media that the true infection rate is as much as 30 or 40%. It depends on who you read. People have been doing all kinds of back of the envelope calculations. But these are kind of firm, credible bounds. Still, they're wide, but I think pretty firm. Now, if you look at the rate of severe illness, we get bounds that look more informative, tighter. This is for Italy, that if you look at the rates of hospitalization, being an intensive care unit, or death in Italy, that they're bounded between 0.1% and 17%, 0 and 2%, and 0.1% and 8.6%. Now let me just focus on that very last figure. 8.6% is an upper bound that we get on the rate of death in Italy. That actually is informative, because the number that's been going around, if you take the statistics at face value, is that the death rate in Italy has been 12.5% as of April 6th. That's if you just take the numbers at face value, which is very high. So we're able to get that down to 8.6%. That's still probably, my guess is that's still much higher than the true death rate, but that's the upper bound that we get. Okay, so those are the results we want to report. There are tables with full sets of results day by day for each of these places on the paper, but this gives you a sense of the summary. Okay, let me finish up. First, some discussion. Come back to this basic question. You get these bounds, and the bounds, basic bounds are still quite wide. You may prefer to get narrower bounds, but there is this logical problem that the only way you can get narrower bounds is to impose stronger assumptions. You impose strong enough assumptions, I could tighten these bounds as much as I want. The problems when Francesca and I really searched through the literature, what we thought was credible versus not credible, we did not see immediately a credible basis to add much stronger assumptions. In the paper, there is one additional assumption that we entertain, and we present results on it based on an expert opinion, a judgment of Dr. Fauci, everyone's been seeing every day. But we do that mostly for illustration because we didn't want to really rely too much on that. If you want to get tighter bounds, you can do it if you want to make stronger assumptions and determine their implications. Let me note that even though we've been trying to take quite some care in expressing uncertainty, there are yet other sources of uncertainty that we abstract from this paper, and I want to list them here. Francesca and I don't think they're the same level of magnitude in importance, but they may well be in some circumstances. First, we assume that you cannot be infected anew, so that once you recover from the disease, then you become immune. And of course, there's been a lot of discussion of that recently. So we maintain that assumption in the paper. We also assume that people who are tested only once. That's obviously not true. There are some people who are tested multiple times, but our impression is the fraction of people who are tested multiple times is fairly small. And so that would complicate the math quite a bit if people could be retested. The interpretation of the testing data would be harder. Third, and this can matter, is we're assuming that hospitals correctly diagnose patients and that public records correctly code causes of death. There's been some concern on that as well, particularly about understating deaths from COVID because of people dying at home and they never get tested. So those assumptions may not be accurate. Francesca and I know how to incorporate them. We could redo our analysis allowing uncertainty of those, but we wanted to keep this fairly transparent. We didn't actually do it in the paper. A very short remark to the econometricians and statisticians here is that when we give these numbers, we don't call them estimates, or these bounds, we don't call them estimates, and we don't provide any measures of statistical precision. And the reason is that you can measure statistical precision by a standard error or a confidence interval or whatever if you have some well-defined sampling process generating the data. But that's not how these data are generated. These are population data. We have full data for Illinois, New York, and Italy. So there is no sampling process that's obvious. So we just stay away from that. Okay, finally, last slide. I've said that the bounds can be narrowed by imposing stronger assumptions. A much more satisfactory way to increase our knowledge of the infection rate is to obtain better data. So I just want to end by posing two things that we think are very important. One I've already emphasized greatly is that random testing of populations would contribute enormously. I mean, that would resolve a very large part of the current uncertainty if we were to do random testing of populations. The other issue is about the test accuracy. There seems to be great uncertainty about the negative predictive value. And whenever I see new tests that are discussed, like the new test from Abbott Laboratories just north of Chicago, I could find no mention of test accuracy in any of what I could find online about that. So I think there's a real need to get data on test accuracy, and we hope that someone will.